Good evening, everyone. Welcome to tonight's living room. Thank you all for coming, everyone in the room, and welcome those of you who might be joining us online, as well as those of you who are coming back to watch us post-live event. We're so happy to have you here tonight. We are excited about the topic tonight. This always tends to be one of the most heavily viewed online, both live and post-live, as everybody's anxious and excited to learn about some of the data and the information coming out of ASCO, which I believe most of you know is the American Society of Clinical Oncology. So it's a huge oncology conference held at the end of May, beginning of June every year. And I don't even know how many attendees there are. It is like
40,000.
Yeah, and attending it, I couldn't go this year. This is my first, the first year in about 9 or 10 years that I haven't attended the meeting. But I always kind of compare it to something like speed dating, because you're just like running all over the McCormick Place, but as well as all over Chicago to different hotels and meetings and really figuring out what's going on. So we're very, very happy to be able to bring you Dr. Husain tonight from University of California, San Diego, and our very own Dr. Amy Moore to talk about what are some of the exciting things that are coming down the pike and that you guys can expect, you know, to be seeing here in the very near future. So we're going to start with the around the room as always. Please tell us your name, who you are, what's going on, any updates you want to share, and then once we do that, we will jump right into tonight's presentation. So, Dawn, I'm going to pick on you because you're on my right.
And just before, Dawn, you start, Dr. Amy Moore is our resident physician here, which we all need desperately. And she's amazing, just in case you didn't know that she's ours. She lives here.
Great, thank you. My name is Don Scranton. I came down from Santa Rosa, California, and I want to thank Bonnie. And you know, it's great. It's a free meal. I'm single, so it's a free meal.
A warm one too.
Right. But in 2006, I was doing volunteer work at a local prison, San Quentin, and I had to get an X-ray to check for tuberculosis, and they came back that I had a suspicious lesion on my left lung. And what I decided was to sort of just bury my head in the sand and, you know, out of sight, out of mind, which with hindsight, I know now I should have probably had it biopsied with a needle biopsy. Instead, it was a wait and see. In 2009, it changed, and my pulmonologist suggested a PET scan. And a PET scan revealed that spot was hot, but I also had warm, but I had a hot spot in my right lung. And they did a bronchoscope through my nose and missed it, the tissue, so there was no conclusive results. They then sent me to Santa Clara Kaiser, where a doctor performed another bronchoscope through my mouth. It was supposed to go in through my lung and down into my lymph node they thought was hot. Instead, he got in there and they found a tumor. I had my bronchus tube 90% blocked. And then they did do a needle biopsy on that other spot, and they staged me at stage 4 adenocarcinoma. Originally, they were going to do 35 hits of radiation before they found out it was in both lungs, so they suggested 10 hits of radiation, and that's when I started advocating for myself. I said, no, if I could have done 35 before, I want at least 15. I want to make sure it's dead before I start chemo. I then was offered Taxol and Carbo, and I said, you know, my friend Jana was here last month, we spin together, and I said, he told me that Avastin was the gold standard of treatment for our type of lung cancer, so I advocated until I got all 3 added to my mix. And then they handed me a bottle, well, they scanned, and I also had nodules in my liver, did another 6 cycles of Gemzar. And then they handed me a bottle of Tarceva and said, take this, and it worked for 6 years. And in 2015, I had a new tumor. I had a blood clot in my leg, and it triggered another CT scan, and I had a new tumor in my left lung. And I did a foundation report. They found out I never had EGFR. I just got very fortunate. I was stable for 6 years. I reached out for a second opinion at Mass General, and they said based on my report and history that I should do very well on immunotherapy. Had 36 infusions of immunotherapy. During that time, I had a lung collapse, had part of my right lung removed, talc procedure, and then in August of last year, I couldn't breathe. Actually, I think I was probably here at one of the meetings right before. Bonnie's talking about don't ignore side effects, and that's what I was doing. And they found out I had 3 liters of fluid on my pericardial sac from immune-medicated toxicity. So they pumped all the 3 liters out, switched me to Tecentriq. I got 8 infusions out of that until this last January, where I had progression in my lymph nodes, and another foundation report said that it was probably 95% effective. I only had 5% malignant cells, so they couldn't even test my tissue. But I always keep a plan B, and I'd already discussed with my oncologist. We had heard about the new triplet, the Keynote 189, so I've had 8 infusions of that, the Keytruda, Alimta, and Carbo, and after 4 infusions, my tumors have all shrunk 50%, so thank you.
Is that all you've done? That's it? No, okay, just checking.
Yeah, and I mean, just a comment, Dawn. Well, Dawn is like a lot of you here, and even anybody new online who might be watching. Dawn is the epitome of why it's important to be your own advocate and why to educate yourself on your disease and why to be open to clinical trials. I know some of you in the room have been on a clinical trial or 2 in the past, but it's really, really a good option at some point, and I would say most people's cancer sort of journey. Yeah.
To Danielle's point, it's harder to unlearn people than it is to teach them. And for decades, people were afraid of clinical trials, mostly because of the name, I think, clinical trial. But they're good. That's where all the new drugs are coming from. And you have an opportunity to be first to get them.
Yeah.
So thanks, Dawn.
Thanks, Dawn.
Hi, everyone. It's nice to see you all again. I'm Ina Bauman, and I've been coming for, I guess, 2 years or so, close to 2 years. I was diagnosed almost 3.5 years ago, an accidental finding of a tumor in my left upper lobe. And because it was accidental, I went in for something else, and same thing, they found the tumor. They were able to remove my all of my left upper lobe and part of the lower, and I've done really well. I mean, I have not needed to have any further treatment other than just we're watching, and I always have my scanxiety. But other than that, at this point in time, I do have lesions on my right side, but I think they haven't grown in a long time, so we're just watching them. And I'm grateful that I'm able to do almost everything that I did before, including some things I never did, because I felt like I had to have some new challenges. So I've hiked some hikes that I never did before, and just really trying to stay physically as fit as I can.
That's what lung cancer will do to you. It'll make you do things you never did before.
I think that's great, and
Right.
it's fantastic, because I think there's a tendency to not want to do that or to feel like you can't.
just,
But
like,
you
wrap
heard
yourself
the
up in a
first 2
blanket
patients,
and
Dawn
hide.
takes spinning classes. I couldn't make it through a spinning class, so I think
I'd
that's
be there
great.
giving him a glass of wine. It's like,
Yeah.
we're both spinning.
Did you all see Linnea's latest post that she got her health
She got
insurance?
it. She got it back.
Yeah. So, and you supposedly were helping with that too,
Yeah,
Bonnie.
absolutely.
So
All
that's
weekend,
great.
last weekend, and from Lake Tahoe, and lots of patients jumped in and wrote letters and other advocacy groups, and she got it back. They called her and said, "Please tell people to stop writing us letters." And we are looking at your second application to get it renewed, and she got it renewed today around 2, 3 o'clock. Yeah,
Yeah, that was
Good
the best
stuff.
news. Yeah.
Insurance.
Yeah.
her
She
insurance
got
was
dropped.
canceled
Yeah.
because she was just a bit late on the payment. Boom, stopped it. So, but we brought in the troops. We had everybody. We had pharma. We had everybody. Yeah, it was a good thing.
Anyway, that's something nice.
Yeah.
I'm Sally, and I entered an early lung cancer assessment program, the ILCAP, and I was at high risk for getting lung cancer because I smoked, but I had quit 15 years prior to that, and I had a lot of family members with it. And they found nodules in all my lobes, but they were just going to watch them. And 5 years later, one grew. And I had lower right lobe lobectomy, and it was non-small cell. I was stage 1A, and I haven't needed any further treatment, but followed because of other nodules that they want to watch. So I'm a very lucky lady.
Thanks, Sally.
My name is Tina, and I was diagnosed in November of 2010. So it's been a while, but I was tested for EGFR at diagnosis, and I did test positive, which was very fortunate. And but I did go through radiation and chemo because they thought that would be better, more aggressive, or something. I don't know. Just do what they said. And then after chemo and radiation, and the tumors were gone, or NED, I guess is more accurate. I started taking Tarceva as a maintenance program, and I am still taking it, and it's been 7 years on Tarceva, and so far so good.
So far, so great.
So far so great. Pretty wonderful.
Yeah.
And happy birthday to Rick.
Aw, happy birthday.
Where else would you rather be?
I had to go out and celebrate my birthday last night so that I could come here tonight.
Right?
That's awesome. That's
But I did
awesome.
get to play golf today. So,
Well, there
There
you
you
go.
go.
That's enough. That's enough.
so the best part of it is that all three of our kids were there, which doesn't happen very often. And Kirsty is back from Japan for good. Back,
Oh.
Done, yeah.
Oh,
Wow.
awesome.
That's great.
Awesome. Now that you
That's it?
moved, where are they all going to sleep? Okay.
Debbie?
Hi, my name is Debbie, and
What's your last name?
Marcus. And I am Fred Marcus, Dr. Fred Marcus' sister. And this is my first time here, and I think I just came here and want to learn a lot about what everybody's going through. The stories to me are very inspiring, and I am so happy to hear a lot of you people are survivors, because that's what my brother would have wanted for everybody too. So keep up the good work, everyone.
So what Debbie didn't tell you is that her brother, Dr. Fred Marcus, his picture is right back here. He was my oncologist, and he's the reason I'm still sitting here today. And he actually was diagnosed with lung cancer after I was, and it became me taking care of him at that point in time. And just an amazing guy. And I just seen you sitting over there just brings me to tears. Thank you for coming.
Thanks, Debbie.
Debbie, you should know that his name comes up, I think, at every single meeting
In some form or
in
fashion.
some way or another.
Yeah, Debbie's an avid follower of the
Yeah.
living room. She watches online, and Fred was sort of particularly for a community hospital doc, a pioneer, in this space and things that you didn't expect, and really sort of corralling multidisciplinary teams and thinking outside of the box back in 2003 when you were diagnosed.
Yeah.
Yeah.
And one thing with Dr. Hussain in the room, that's a good thing for him to hear. When Fred was diagnosed, and he was lucky enough early on to have surgery, and when he did, I was talking to him one day when he was at home recovering, and he said, Bonnie, he said, I just have to say I'm sorry. I just didn't know. I had no idea that a surgery like that could just wipe you out like that, and I just didn't know. And I said, that's okay. We're gonna get this together. So when you're a physician and you say, 6 weeks, you're gonna be fine. not going to be fine in 6 weeks, except unless you're Evie, you know.
She's right here. She just
Unless you wear a jean, you know. Yeah. So,
That's what he said to me, it's hard to step
yeah,
into the
yeah,
position,
yeah, yeah,
being a physician when you have to
yeah.
turn around
Come on.
and be the patient instead of the physician. And that was probably the hardest thing for my brother to have to do.
Yeah.
And to give up his practice was probably even harder.
Right, right.
Hi, everybody. I'm Jason Yanahiro. I'm just happy to be here. I'm a patient advocate. I'm learning more and more about lung cancer, and just being here and hearing your testimony just kind of adds to my conviction and the advocacy that Bonnie and the organization has brought to patients. So thank you so much for letting me attend.
Thanks, Jason.
Thank you for coming.
Mr. Dave.
I'm Dave, and tonight I'm going to have Barb do the honors.
Oh, I like it.
Because Dave is a little wiped out. We just got back from our 2-week trip to Portland, Oregon, where we were trying to keep up with our 2 sons and their wife and fiance. So, yeah, it was 108 when we stopped in Redding last night. So we were really happy to get back to the Bay Area and see a little
Yeah.
fog bank out
Right,
there.
exactly.
Anyway, Dave was diagnosed last year ago, March, with stage 4 adenocarcinoma. He had a tumor in his lung, a lymph node that was cancerous, and also cancer cells in pleural effusion in his lungs, as well as mets in the brain. And so he was treated with stereotactic radiosurgery, SRS, for the mets in the brain. And then he was put on Tarceva because he is EGFR positive. And so he's been on Tarceva since basically almost the time of diagnosis. And things have been pretty good. A lot of stuff was shrinking. And then back in January, the lymph nodes started to increase in size. And then they said, well, we're just going to watch it because everything else looks stable. And then the next scan kind of showed it was okay. And then in June, again, it had increased a little bit. So I think those of you, when we left you last month, we were just waiting for the results of the liquid biopsy, which unfortunately didn't show anything. I mean, it's good and bad. There was basically not enough cancer cells there to be able to determine anything. So following that, his oncologist decided that she really wanted to do a tissue biopsy of this lymph node. And she had it scheduled with somebody, and then the guy took one look at Dave's scans and said, no way, I won't touch it. The lymph node is actually kind of wedged between the aorta and the pulmonary vein. So very, very tricky. So she said, no, we're referring you to somebody else. This guy is going to go in and basically go down through the bronchia. So, of course, I don't know, can we say, we can't say bad words on TV, right? Okay. No. So we were scared blankless
Sure you can.
by all of this. And so, of course, what do? We called the foundation. We said, is this the right thing? Should we be doing this? This sounds really risky. They're sending us to some guy down in Mountain View. We don't even know him. We came in and we met with Danielle and Michelle, and they said, oh, God, this is like the best guy in the world.
Right.
He's like the best guy in the world,
Right.
and he's the
GPS
best
guided.
person to do
Yeah.
this, and this is absolutely the right thing. We were like, oh, okay.
Right.
So we went to bed and we
Yeah.
went to sleep. It's like, okay.
Yeah.
And so we were very, it was, thank you guys, because time and time again, we have turned to you when things are really, dicey, and you've had answers for us. So anyway.
Who was that doctor?
That was Dr. Krishna.
Yes.
Dr. Krishna down in Mountain View.
Yes.
Okay, he is amazing. And his fellow that's working with him now, Nate, who's new. I don't know if you guys have met Nate, but anyway. So we had a consultation with them the afternoon after we met with them, because we said we need to talk to you before we talk to them. They told us all the questions to ask once again, so we could go in there sounding really smart, and then they think you're like really impressive. And then he had the procedure the very next day, which was Tuesday, the day we were supposed to be leaving for our vacation. So we were driving, so it was okay to push it off. And then we said, well, can we still leave the next day? And he's like, yeah, sure, why not? So he had this biopsy on Tuesday, and he came in, and it was really interesting because one of the things that's important is that the oncologist wanted to get this biopsy because she was trying to decide if maybe they should be radiating this lymph node. And if that was going to be the case, then they could put these markers in at the same time they did this biopsy. But what we learned, because Dr. Krishna consulted with a radiation oncologist friend of his, because ours was on vacation, that it is not, he said he does not believe that it's possible for them to radiate it based on the location. So we know they took several samples. They were able to get samples. Dave fared the procedure just fine. He called us last week and said, well, on Tuesday, and said, come in Thursday. I want to go over the results with you. And we said, we're in Portland. And so we didn't get to see him. And he said, well, I'm in ICU all next week. So we see him a week from Monday.
Oh, geez.
So, okay. So we don't know, because our regular oncologist is also on vacation. So we don't know, these results are out there floating somewhere. But we figured if he needed surgery right away, they would have called us.
Okay.
So
Okay.
we're waiting for the results of this tissue biopsy. Meanwhile, we have Thursday is his next brain MRI. And then Monday, we have the meeting with Krishna. And then Tuesday, we have the meeting with Colin at UCSF for a
Wakelee.
second opinion to look at everything. And the following Friday, we go back to our radiation oncologist to see what he thinks.
Okay. Did anybody mention osimertinib?
Tagrisso.
Tagrisso.
So we talked about it, and when they came in before we left. So some of you were here when Dr. Blakely came, and one of his areas of expertise and interest is in resistance, particularly EGFR resistors. So he's doing a lot of work in that area. So the timing was sort of serendipitous with all of this going on.
We're pretty sure you picked it just for us.
Yeah, we did. We did. So we got Dave set up to go in and talk, and they're trying to figure out the T790M because the Garden test didn't come back.
Yeah,
So did they run that? Did Dr. Krishna run that test, or did they send it off to Foundation, or they did?
Okay, good.
So it's
Okay.
Do we know?
Okay.
We think it was Foundation. We told him that's what the oncologist had wanted, so I think
Okay.
that's what
Okay.
it is, yeah.
Okay. And you're going to go back to see him when?
Monday.
Monday.
Oh,
Okay,
yeah,
cool.
Monday.
Good.
So we got a lot of stuff.
Good,
So
good,
stay
good.
tuned
Okay.
for next
Great.
month.
Thanks,
Okay.
guys. Let's let Evie go before we go to the outer circle, because I saw you sneak in and sit down and
Yeah.
you're holding a mic.
Yeah.
Is this on?
You ready to talk?
Hello?
Yeah.
Anyway, hi, everybody. I see a lot of familiar faces here. I came first to the Dario Foundation from 2011 to 2015. I was a caregiver for my husband, Neil, who was stage 4 lung cancer. The end of this month marks the 3rd year of his passing. So now I'm back as a patient, as a survivor. I was diagnosed on May 29th as having early stage lung cancer. My story is quite amazing in that it was totally unsuspected, incidental finding, because I had gone to have a coronary scan to look at my calcium score for blockage, for risk factors for heart disease, heart attack, and stroke. And I came back 0%, I'm clear, but you got a mass in your lower left lobe. 4 weeks ago tonight, I was in surgery because they started late in the afternoon, and I had my lower left lobe removed, and I am now NED, and so I am world's luckiest person, and early detection is the key, and we all know that. So I'm
But
on
not
a mission
accidental
now.
early detection.
Well, one of the things that's interesting about Evie's story is Evie doesn't qualify for screening based on what the current standards are. So
She never would have
She's
gotten a
lucky
scan.
it was an
Right.
incidental finding. Yeah.
Right. I'm so very, very fortunate. And really, there was no reason for me to have this test other than the fact that I was worried about my risk factors for stroke, because it really scares me. And I heard about the test because I had read an op-ed piece in the Mercury News in February. I saved that article until May when I went for my Medicare physical, and I said to my doctor, should I have this test? And he said, sure, go ahead. You have it. I don't think your insurance will cover it, but go ahead. My insurance covered it, which wasn't going to be the determining factor. And all I can say is, thank God I had that test. So anyway, it's good to be back. This is the first living room I've been to since Neil died 3 years ago, because we always came and we sat here together. And so it was a little bit difficult for me to come back, but I'm back now. And I want to thank everybody at the foundation, because Danielle and Michelle and Bonnie all helped me so much, that I went from 529, 4 weeks later I have surgery, or 3 weeks later I have surgery, and 4 weeks I'm here. So.
And even though Evie has not attended a living room, understandably, she is one of our #1 volunteers and is here on the weekly, multiple times a week, helping out various different things. So, aw.
But you know, that story is just so amazing for everyone to hear, and people online to hear, and people outside of this room to hear. Because, you know, we're probably at 65% now of people being diagnosed with lung cancer that either never smoked a day in their lives or quit smoking decades ago. Lung cancer is not a smoking disease, and we have to change that. We have to change the stigma, because that's what's keeping, you know, research from happening in lung cancer. The percentages just aren't right, and that's why Evie is sitting here today. She is determined. She is one determined 70-pound little minute that is going to just lead the parade on early detection.
Yeah, yeah. There's a lot of, I mean,
There's a lot to
certainly
learn.
smoking is a factor, but it's not only smokers that get lung
Right.
cancer, and we talk about it all the time.
Yeah,
so.
smoking is not a good thing, and no
For a
one
lot
should
of reasons.
smoke.
Yeah.
But you know, the jig is up. We have to stop. You know,
Just say one thing about smoking. The only reason I always say it, that I was a smoker, was because you had to have that to qualify
Right.
to be in this thing. Other than that, I don't go around saying I'm an ex-smoker, but
yeah.
it's just important to
Well,
know that is one of the qualifying.
Yeah, and I mean, it's currently one of the qualifying things to qualify for screening, but I think it saddens me every time I hear something like that, Sally, because there's some sort of shame blame attached to it. There was a time in the not so distant past where smoking was a glamorous thing, it wasn't a taboo thing, and you know, to continue to point fingers at people who ultimately wound up addicted, I think is insanely unfair. And so I personally applaud you every time you do say it, because it brings
Absolutely.
a face to you know, a population of patients who feel like they don't have one. So,
And it's just harder to unlearn people than it is to teach them. You can teach a 3-year-old so many amazing, I mean, how to operate a laptop, you know, but once you get something stuck in here, it's really hard to get it out. So, and I think, you know, with stories like Evie's and others, you know, we're going to change that.
yeah, absolutely. Betty, I saw you sneak in. Do you want to introduce yourself? Somebody grab, here comes Bridget with a mic.
Hi, my name's Betty Corner. I'm diagnosed in September 2014. I'm a never smoker. I coughed up this little tiny speck of blood, and it seemed a little odd to me. I thought, sinus? I don't know. And I called my advice nurse, and they said, how about you come in tomorrow morning? And I told my doctor, and they just sent me right on through, and I got all these tests, and unfortunately, the test showed that I had a mass in my right lower lobe. They're all set to take it out, but then the MRI showed I had a couple of brain mets as well. I'm in an unusual situation. They call it oligometastatic. And although I'm stage 4, I don't know, stage 4 light, what would you call it? It's very rare. I recently was speaking to my oncologist, and she told me I'm the only one she's seen. So however, that was lucky for me. Again, as early as it was diagnosed, they were able to treat me. They used CyberKnife on my brain mets, and because I was EGFR positive, I was tested for that, EGFR positive, and was responding well to the Tarceva, they were able to actually resect my right lower lobe. They took out my lobe and found no lymph nodes or anything. And I have been pretty clear since then. I had a little bit of swelling in one of the places in my brain, and they were concerned enough that we ended up going in there and looking, but it turns out to be necrosis. So I've very luckily have had no cancer since then. So since 2014, so I'm very lucky. Thank you.
Thanks, Betty.
Oh, one thing, I do yoga. And I started doing that at diagnosis because a lot of doctors told me to do it. And for all the things you can't do, that's something I could do, or I do badly. And I loved it. And it was like I couldn't make the scans work. I couldn't do any of that stuff, but I could try and straighten my leg or try and do. The breathing has really helped, and I think it really helped my operation when between September and January, when I had my surgery. I did that yoga a lot, and I still do. And I would really highly recommend whatever works for you, any kind of exercise, but the yoga has been great for me.
Thank you.
Thanks, Betty. I'm going to take it back. I don't know if you want to. Thanks, Bridget. I know Ben's not going to want to talk, so you can just pass him.
Okay.
Yeah.
How about the other little?
You want to talk?
No.
Hi, my name is Wayne. Caretaker for my wife, Rebecca here. She was diagnosed in November of 2017 with adenocarcinoma stage 3B. Took a couple of weeks delay from the insurance to get her chemotherapy started. Also, before that, she insisted that they take another biopsy from her primary tumor, but we got talked out of it. And then later on, so we found out that that sample couldn't be used at Foundation, so we just went on with chemotherapy till February. Then after that, we started immunotherapy for about 6 to 8 weeks, and we found some additional millimeter-sized nodules in her other lung, and so the oncologist recommended that she does VATS biopsy, which she did last week. And she's incredibly strong because she's here today, despite a lot of pain and medication. And that got sent off to them, and we're hoping to wait for the results for that. And yeah, that we had another 1 week delay for that other procedure is due to the insurance also. So we've been having bad luck with insurance. But we're just waiting to see what the results are so that we could formulate a plan and to get more answers. So that.
But you still don't have any genomic marker information?
No.
After how long?
9 months.
Oh.
So it takes a while, and if well, they talked us out of it, and they thought they had enough, but have we?
The original sample there wasn't enough tissue.
Yeah.
And then they talked them out.
Actually, there was not enough % cancer. They had enough tissue, but there was not enough cancer in the specimen. Okay. So who knows? But,
no blood biopsy.
We did about 3 or 4 blood biopsy, but they didn't show up with anything.
Okay.
So.
Thanks.
Wayne, what was the original biopsy called?
CT needle guided biopsy.
Got it. Thanks.
So actually, Dr. Krishna M was supposed to do a bronchial biopsy, but the insurance denied that claim. So they have to wait a week to do a CT needle biopsy.
My name is Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013. I'm currently on immunotherapy and stable.
Thanks, Fred.
Thank you, Fred.
Hi, my name is Ron Fong, and I'm here as a lung cancer advocate. My wife had stage 4 non-small cell lung cancer, an EGFR mutant. She was not an X-man, but she was a mutant. And she passed away about a year ago. So lots happened in the last year, but fighting for lung cancer is good, and being in a clinical trial is really good. If you're not in one, you should consider one, because I think the standard of care in a clinical trial is much better than the standard of care elsewhere, because they don't want you to die. They want you to be healthy, sick, and make that new drug therapy work. And so that's what they want you to do. And they're watching you very closely, more than your regular doctor would. And then with that, Joan was in 3 clinical trials, phase 1, and we were trying to get into 2 others. And I think because of that, she lasted longer. And it's because of Bonnie that we're in these clinical trials. So thank you, Bonnie.
Thanks, Ron.
My name is Michelle Stewart, and I'm here today because this is all very, very new. My mom was just diagnosed in March with stage 3. She's 82 years old. She lives in Phoenix. And over the last 4 months, I've spent the majority of my time in Phoenix helping my mom. She's had 37 radiation treatments and 7 chemos. The scan that we had 3 weeks after she stopped or ended her treatment showed that the mass had shrunk in size and had not spread. So that's good news. But now that I've found this great foundation and spent some time with Michelle today, kind of my eyes are open, the doors opening as to some options, some things that we need to consider. So even though my mom has made the decision that she does not want to go forward with any additional treatments, the recommendation are these 2 super blast of chemo that are about 5 times the strength as what she's had before, and she hasn't tolerated it well at all. And she just doesn't want to feel sick anymore. She just wants to be done with it. So I'm going to explore some options with your help, and as well as before even that part of it came about is that I had, since late last year, I've been wanting to volunteer somewhere, and somewhere that meant something important to me. And then my mom gets sick, and it's like, okay, this is where I'm going to be. So I'm here to be a volunteer, and you guys have some great projects for me, and I'm happy to be here and join this family and kind of twofold, help my mom and fulfill some things that I want to take care of for me personally. So thanks for letting me be here, and thanks for the help.
Thanks, Michelle.
You're welcome, sweetheart.
I'm Ron, and I'm the caregiver.
Yeah, they're Ron.
Go for it, Ron. It's a great name.
That Ron just wanted to just make sure you knew he was number 1.
So I'm the caregiver, driver, the person has to keep the lady on my left in control, and I'm looking very much forward to the presentation tonight, and I'm going to let Joanne give you her a little bit of history. And by the way, Dave, that shirt of yours looks great on television.
Dave always dresses for the camera. Hi, I'm Joanne, and I was diagnosed stage 4 in September of 2016 after a full year of misdiagnosis, which I always make a point of, being diagnosed as postnasal drip and acid reflux and this was constantly coughing. And finally, there was a chest x-ray and a mass showed up, and then the PET scan, and then I was sent to Dr. Krishna for the biopsy, and he was absolutely wonderful. And as a matter of fact, I knew about Adario from Jackie McNamara, and when I mentioned to him about that, he said, "Oh, I know all of those people."
Those people.
And those people, that's what he said. And he was, of course, very complimentary about the organization and encouraged me to get in touch and so forth. So that's that. A shout out for Dr. Krishna tonight since he's come up. I did have, or do have, the EGFR mutation, which is, among all the things you can have, a good thing, and have been treated with Tarceva for almost 2 years, and with the full 150 milligram dose. At this juncture, or with about a month and a half ago, it did start to affect my scalp pretty seriously. So in conjunction with my PAMF oncologist and Dr. Blakely, we have reduced the dose to 100 milligrams for just 2 months. Try if that if that makes a difference, and then scan, and if everything's fine, stay there. If everything's not fine, reassess, either go back up or consider Tagrisso. There are some options. The scarf is, let me explain, is not because of that. It's because I slipped on the stairs at home, went sliding down on my right side, and I sheared skin off of this arm, long sleeve shirt, and off of this side of my head, hence the scarf covering the dressing. All is well. I saw the wound clinic today. It's a 2-week mark, and the head is almost fully healed, and the arm has about a week to go.
Were you by yourself? Were you by yourself?
No, Ron was there.
Okay.
No.
Okay. Was he any help?
He called 911, and this was huge trauma, bigger trauma than the lung cancer. But I was well taken care of at the Stanford Emergency Department, and there will be no long-term effects, but just wanted to explain that.
Thanks, Joanne.
Thank you.
This has been like a, we have to tell Ganesh he has to come back and watch
I
this.
know.
This has been like
All
a Dr. Krishna commercial
We have
tonight.
to
Yeah,
get him
it's
up
hysterical.
here. We have to get him up here for a living room.
Hi, Rick.
Hi, I'm Rick Bryson. I was diagnosed in February of 2015 with stage 4 adenocarcinoma. I was treated at Kaiser Santa Clara. I went through 7 months of chemo. Then I had some progression in the tumor on my adrenal gland. And I was able to have that surgically removed and went on Taxotere for 4 or 5 more cycles. And then in February of 2016, my scan came back clean, and I've been NED for almost 2.5 years now. I did have a DVT blood clot in my leg about a year after my last chemo, but doing well now, happily retired, volunteering when I can.
Talking about the DVT blood clot, what did you do for that? What were your symptoms, and what did you do? Because I think that's important information for people to watch out for.
Okay, I was, during chemo, I was on Lovenox, self-injecting twice a day. And then I had stopped that in June of 2016. And then in March of 2017, my left leg just swelled up like a balloon. And it took a week. And then I called my my primary care doctor, and they said, just drink lots of fluid, put your foot up, and then it took another week. And then when I couldn't walk outside the house, then I went into the emergency room, and from there they admitted me straight away. And while I was getting my DVT rotor-rooted out, they also found that I had an appendicitis that happened as well. So they took care of that while they were in there. But it's been over a year now that I've been out of the hospitals just doing scans. One's coming up next week.
Lesson learned, though.
Thanks.
Swollen leg is something to pay attention to right away. Right away. Right
I had one
away.
in 2015, and another trick, you post it on Facebook, and you get some good.
Right.
Somebody said that could be a blood clot. You better get to the doctor.
Exactly, and which could end up being a pulmonary embolism. So, yeah, don't fool around with those things.
And I'm going to sell you out for a second. So you threw 3 PEs, and I think she was were you at dinner with Danny? Yeah.
Yeah,
They were
it
at
was your
dinner
fault.
down here, and my
cosmopolitans.
stepdad was out of town, and she was just having trouble breathing, but she was like, meh, I was going to stay with dinner, but then it got worse and worse and worse. She's like, I think I should go home. She goes home. It wasn't until the next day, right, that Tony came home. Now she like literally is like gasping for air. He was like, let's go to the hospital. She's like, no. He's like, no, we're going.
Yeah.
And they went, and she had 3 pulmonary embolisms. Yeah.
And then they put a filter in, but I still another couple more snuck through, and I was actually in the ICU for quite a long time.
It was a
so
lot. Do not ignore your symptoms.
do
We say
not
it all
ignore
the
your
time.
symptoms.
Right, Dawn?
You know, no.
I think you would probably
Right,
acknowledge
I know,
that
right. I
thrombosis
usually
can be a
don't, though.
common complication in cancer, and part of the process of that can lead to
No,
clots.
I think that's absolutely true. And sometimes we get so fixated on some of the more common things around scans in the lungs and looking at that.
Oh, he's fine.
But realizing that lung cancer kind of affects the whole body.
Right.
And that actually kind of means the vasculature by virtue of changing some of the cytokines and molecules in the blood to actually increase the chances of clotting. So I think it's actually very sobering, just to hear all of your stories and everything and understand actually how the disease affects broader than just what's seen on a scan.
Yeah. Yeah.
I think we just have a couple more and then
So
we'll
we
drop.
have a couple more and then we'll
okay.
start.
My name is Ranlong Zhou. I was diagnosed lung cancer with a squamous cell, stage 3, back in 2014, November. So I've been attending this living room since then, and it's always a great feeling to be here. Not only the knowledge and the encouragement, the warm atmosphere, the welcome, and also all the friends and the stories, very encouraging, and I really can't appreciate enough for this foundation and all the work you've been doing, and plus all those professionals giving us all the knowledge and the latest update. Thank you for that. People are talking about Krishna, Dr. Krishna. I want to make sure that we're talking about the same Dr. Krishna from Palo Alto Medical Foundation.
Yep.
So same story for me. I want to add a quick update.
They should be sending us a rebate, by the way. Just saying.
Yeah, when I was doing the biopsy, about 3 days after I did the CT scan, so he was doing the biopsy in El Camino Hospital, there was a technical issue that he mentioned because my insurance Cigna, they don't somehow cover one of the technology that they included called a computer-guided, computer-aided, somehow like a thing like that. And they said that my insurance does not cover. If it's a small amount, I wouldn't mention to you. This is what Dr. Krishna said to me and my wife. He said that they charge about 30 grand for that computer-guided technology. Then I said, so what option do I have? There's no time to call the insurance. They already said they don't cover. But the procedure they're doing in El Camino Hospital, that's part of the standard. So what Dr. Krishna later on mentioned to me that I don't want you to worry about this at this time. I know what's more important to you is to do the biopsy because I'm so eager to know what exactly I had. So he said that I can't promise you, but based on my experience, I have the confidence to not use that computer-guided technology to do it. Because before this thing got introduced, I've been doing that without it. So if you said, okay, then I'll do it. Now, of course, I said, let's do this. And then my wife added, if you're not confident, let's put that thing in, whatever computer-guided. My wife is so eager. 30 grand. So we have a house to cover that. Okay. But anyway, when I wake up, Dr. Krishna wake up and come back to me and said, I have some good news and bad news. So the good news is that I got it. And I got that. The bad news, I confirmed. It is a lung cancer. So at least, we didn't use that computer-guided thing. Saved us 30 grand. However, I get whatever that mass is, confirmed it's a lung cancer. So I so much appreciate Dr. Krishna as a professional and how much that he comforted me and before and after, tell me the truth and in the right way and do the right thing and focus on most important thing. So anyway, that's what I wanted to about Dr. Krishna. A doctor like this always deserve our highest respect. Okay, and what I have 3 years from now, I did a 3 round of chemo in Stanford, and later on, Dr. Schwega took me and did the surgery. So I had a left lung pneumonectomy, and I have been clean ever since. So my last check is in May this year, and so far so good. It's clean so far. All right, thank you.
That's great. So just for Dr. Hussain, so Dr. Krishna is an interventional pulmonologist, if you didn't pick up on that. So we send a lot of our hard to reach, patients with hard to reach lesions locally down there to him. But he's at Palo Alto Medical Foundation, but he is affiliated. Yes. Yeah. Well,
Yeah.
it's the, yeah.
Not my favorite. She gave us a death sentence. It's a he. Actually gave us a death sentence.
Yeah. Dr. Krishna, so Dr. Krishna, for those of you who might be watching online, we do work with interventional pulmonologists around the country. So if anybody is interested or being told that they cannot, that they have a lesion that is that can't be biopsied, please feel free to reach out to Michelle, and she'll help you. Yeah. It's a man. I think we're talking about.
We're talking about two different. No.
Not the one we're talking about.
Not the one we're talking about.
This is a different one.
Okay.
Yeah.
Yeah.
He was just horrible to us.
Yeah.
Okay.
Yeah.
Different person.
Sorry.
Okay. That's okay. It's okay.
We got a new group. We got Dr. Germany. We've got a good group. My husband's still 4 years. He's great.
Yeah.
But she was not.
Okay.
That was a different. Okay.
Yeah. It's different doc.
Okay. Sorry.
Yeah. Okay. That's okay. That's all right.
I know. Okay.
This is free speech here.
That's okay. No? We're done? Okay. Anybody online want to say hi or say anything before we move in? Oh, good.
Okay.
So one of the
Okay.
interesting things,
Okay.
so for some of you, I know, Debbie, you watch online sometimes, Ron, I know you have. When we're doing this live sort of thing, they're doing it online with one another. So they're chatting with one another while they're listening and while we're chatting in the room. Thank you all for sharing your stories. As a couple of people said, it's really helpful for you all, one another, to hear each other's stories and kind of learn from one another. But I think it's also helpful for whoever's speaking that night to know who their audience is, so you can kind of, as we're going through the presentation, tailor it to some of what they've heard in the room. So we are going to move into the presentation, but first I'm going to ask Dr. Hussain and Dr. Moore to introduce themselves, because I could do it, but historically I always feel like I'm reading some bio off a piece of paper, right? And it comes across much more personal if I let you just do it yourself.
Yeah. No, well, thank you. And so firstly, thank you for the honor of being here. It's really an amazing opportunity to see so many patients all together in one spot, all kind of reflecting and being very candid and frank about their experiences. And it's helpful for us to actually become a better doctor as well. So my name is Hakim Hussain. I work at the University of California, San Diego, and I've been over there for about 6 years. Prior to that, I was at Johns Hopkins Hospital. And
that's okay place, yeah.
Both, yeah. Yeah.
Yeah, I learned a lot. And some of my areas of interest right now are specifically actually the EGFR mutation, as well as better understanding how we can increase the immune system's ability to respond. And that may involve figuring out how to effectively combine different agents with the immune system agents as well. So with that, actually, I'll pass it on to Amy.
Well, hey again, everybody. So I am Dr. Amy Moore. I'm the Director of Science and Research here at ALCF, and everybody picks up on my drawl. So I did just move here from Georgia about a month ago. My family came to the Bay Area for my husband's career with a vaccine startup that he launched from his faculty position back at Emory University in Atlanta. But it's a thrill for me to be part of this organization. By way of background, my PhD is in microbiology and immunology, so I actually trained as a virologist, worked with viruses, but then transitioned into cancer research as a postdoc at Vanderbilt University. But then about 10 years ago, I joined a statewide initiative in Georgia that was launched by a former governor that sought to leverage some of our tobacco settlement dollars that the states received by suing the tobacco industry for the harm that they inflicted on the public. And along with Hamilton Jordan, who had been Jimmy Carter's chief of staff, they said, we really need to take this opportunity to move the cancer needle here in Georgia. We need to improve outcomes for our patients. At the time, we were one of the largest states not to have an NCI-designated cancer center. We had high rates of disparities, particularly in the more southern rural parts of the state. So, we launched an effort that, first of all, helped recruit leading cancer scientists across our academic institutions. We know through Alchemy the importance of having access to patient specimens. So we launched a biorepository initiative, and then had some smaller seed grant initiatives that were funded by taxpayers, but sought to give seed grants to particularly young investigators to give them the pilot data they needed to be competitive for larger federal funding. And so it's good for me to be here and to get back to my cancer roots, but also to be so closely connected to all of you, the patients. And the work that we do is really in service of all of you. So that is what drives everything. I mean, that's what we were founded for, is patient-focused, patient-centered. And so, it's a thrill for me to be here with Hatem. He, I think, did all the heavy lifting on this presentation, but I think my takeaway being at ASCO was, it's very appropriate that we're sitting here with the word hope on the wall, because lung cancer historically has been so challenging, to treat. But I think the sense of hope at the conference was very palpable, and there a lot of exciting takeaways and advances that are being made in the frontline management of this disease. And I think as we go around the room, it's even, more moving that we have so many long-term survivors here. And, we didn't see that in the past. And so we are making inroads to treatment of this disease through advances in immunotherapy and targeted treatments. And so together, we're going to try to highlight a few of those advances that were discussed at this year's meeting, and hope that it'll be beneficial for all of you. So without further delay, I want to turn the floor over to Hatem, and we'll try to tag team this discussion.
Sure. And I think I'm actually going to take the liberty to actually sit, because I think it's a little bit more informal to actually do that. So today, actually, we're going to speak about some of the major messages that were portrayed in this large meeting, and Bonnie has kind of referenced actually how large it is. It's actually one of the focal points of each year for oncologists, because that's where a lot of the new data comes out. And this year, actually, there was significant amount of data that was presented about how the immune system can be important in lung cancer, as well as further definition of new data about some of the genes that are responsible for causing lung cancer. So what we're going to do is we're going to dissect out some of these two focal areas, and then bring up the highlights and main points. So those main points, actually, I've kind of focused around four major areas. And the first areas are those points that directly involve impacting the management of non-small cell lung cancer. And again, that's the large common denominator for which many different subtypes exist. We're going to speak about advances in small cell lung cancer, which was historically one of the more common cancers, but because of decreases in smoking patterns, actually has now become more rare. And then reference also mesothelioma, because there was some references to new advances in that parallel what we have done in lung cancer. We're going to speak about some of the advances in the gene-based therapies, and that has really truly been revolutionary. And we've heard many stories about how new drugs for the gene-based diagnoses can be important. And then lastly, we're going to hint on a point that was raised earlier about early detection, and how actually it doesn't have to be an incidental finding, but maybe one day actually there will be the capacity to kind of really effectively develop a strategy that can really reach out to patients.
And I'll just interject quickly that, looking at these highlights, I think, several of the leading experts in lung cancers have said, this is kind of paradigm changing. This is, this changes the standard of care today, right now. So I think that was really impactful. That we're not waiting anymore. We're seeing the fruits of all this research and effort. And so,
no, interestingly, a lot of people working in this space have really looked at the lung cancer advances, and have even kind of thought that what's happening in lung cancer is unprecedented, even compared to how things have unfolded in the last year in other cancers. And I think it really is true testament to kind of, some of the standing on shoulders of people who really kind of have carried the way and led to some of these advances. So by matter of reference, it's really important that we all understand that lung cancer is not just one disease. And we now actually better characterize lung cancer through a microscope, histology. And the most common denominator is called non-small cell lung cancer. And even that actually has been further fractionated out into different histologies. Adenocarcinoma is a large component and actually the largest denominator within non-small cell lung cancer, and then squamous cancer. In both of these divisions, there have been big advances. Some of the earlier advances prior to this year have been how do we fractionate out and understand that even adenocarcinoma is not just one disease. We now know that squamous is not just one disease. In fact, actually, some of the recent work has actually even shown that EGFR mutated one disease is not one disease. And actually, Dr. Colin Blakely has kind of done a large work with Trevor Bavona, really kind of understanding some of the fact actually that even a mutationally homogeneous cancer can have many underpinnings that define out why one patient who has an EGFR mutation may do differently than another patient who does. So with that in mind, in this context of how diverse the cancers are, some of the things that were sobering to me seeing this meeting were the fact actually that there were very clear common elements. And some of those elements actually revolved around the fact that immune-based therapy has really moved into each of those subgroups. And we, I want to take pause and note that some of the oncogene-related cancers, the checkpoint inhibitors or immunotherapies still actually have a long ways to go in terms of our understanding about how to integrate those into those types of targeted approaches. But for the vast majority of patients, this meeting brought to light the fact that checkpoint inhibitors, called PD-1 inhibitors, could be integrated into the frontline management of cancer, even preceding chemo, and actually outperforming chemo. And specifically, actually, some of the background behind it was based on tumors actually that express high levels of a marker called PD-L1. And if those levels actually exceeded 50%, one may just need immune therapy and be able to spare or forego chemo for that frontline period. What was shown in this meeting was that when one looks at lower PD-L1 expression, there can be benefit with checkpoint inhibitors, and we're still understanding what the right cutoffs are for the PD-L1 expression that would define just PD-1 inhibitors versus the combination of chemo and PD-1 inhibitor. And so that's why I think it's very important after this meeting that we all know what PD-L1 level was diagnosed in the tumor. That's called a tumor proportion score, TPS score, and that's a percentage. And so understanding whether or not that's greater than 50%, between 1 and 49%, or less than 1%, I think is important because it helps to define out the therapy.
I have a question. Can that change if a patient gets chemotherapy or TKI first?
Yeah, so that's a really good question.
Can that affect the percentage of the
So that's a really good question, and we know that radiation can upregulate PD-L1. We know that certain forms of chemo can upregulate PD-L1. But I think one of the sticking points is that not all chemotherapy works the same in terms of how it modulates the immune system. In fact, actually, some chemo that wasn't approved in lung cancer initially, but may have priming effects with the immune system, may be important to revisit because while they're not commonly used in lung cancer, for this purpose in combination with immune therapy, may have a new role. And so some of those drugs are different types of platinum drugs or anthracycline drugs, other drugs used in other cancers, but in lung cancer were never approved in that way.
I think that's one of the things that scientists are looking at is how are, and you're going to get to this, but how do chemotherapy and immunotherapy interact and kind of cooperate? And cancer is very tricky. It can hide from the immune system through different mechanisms. It can downregulate the expression of certain proteins on the surface of the cell to kind of make it go undercover or to hide. And so chemo may be able to kind of boost re-expression of some of those molecules to make it visible to treatment again. And so that's where this combination approach might come into play is
No, I think that's really good point. And I'm sorry, just to kind of reference one point is that the doses of chemo are very important. And we may not need the traditional higher levels of dose, but we may be able to facilitate the same thing with lower doses. And I think that's an active area of study.
And hence the serious need for patients to be educated so they can go back occasionally and educate their physician.
Yeah.
Because not all of the physicians practicing are as up to speed if they haven't been to ASCO and they haven't been to CME courses.
And for those who may be interested in taking a deep dive into PD-1, PD-L1, what we're talking about, what those things mean, how it all works. We did a remote living room in Ohio in April, I think. Anyway, we were at Ohio State University with Dr. Carbone, and we took a deep dive into sort of the whole concept behind current immunotherapy.
He has a nice schematic coming up too that just kind of illustrate which cells are these different molecules expressed on and what's their normal kind of function and role.
Great.
I think that's a really good point. Yeah. So, just to extend on that point is that there was data preceding the meeting to suggest and actually an FDA approval for the combination of chemotherapy and immune therapy. I think some of the advances in the meeting were that if we look at squamous cancer, for which historically there's been no change in the frontline management for over 10 years. Some of the data was very compelling looking at the combination of the immune inhibitor plus chemo. And so paralleling what we saw in adenocarcinoma or non-squamous cancer. So I think kind of some of the things to stay tuned on are that we may see that FDA approvals come for immune therapy in combination with chemo for the squamous histology. And
is it, so one of the things I kind of want to get your opinion on, obviously, and then have people really kind of pay attention to is the sort of the food for thought is that regardless of what type of lung cancer, what type of adeno, whether you have a target or not, that immunotherapy is in the future of a lung cancer patient, regardless of those things. Is that?
So I think it's true. I mean, I think there are certain small percentages of patients who we still need further clarity about how to integrate it. But I think for the vast majority of patients, it's going to be a player.
Right.
And it's going to be a player across, as I mentioned, histology, the adeno, the squame, but also there was a press release recently submitted actually about small cell lung cancer. Now actually kind of potentially having good data in the front line in combination with chemo. So I think this strategy of chemo plus immuno is probably here to stay. And I think we better need to understand as a field, what are the right chemo agents? What is the right dose for chemo? Because the traditional doses may be too high, causing toxicity and even kind of dampening an immune response to what it could potentially be. And I think we're going to need somewhat of more extended biomarkers about how to understand the pairing. And those are all areas kind of active research.
But still, one of our friends from MD Anderson, John Haymock, says, based on kind of what was presented here, lung cancer patients, if they don't have, a targeted mutation, then immunotherapy really becomes an option for kind of everybody else. That we are reaching that point where there, we have these various tools in the toolbox, and so there are more options available for kind of everyone.
Yeah, and I think that was kind of my point and what I wanted to drive home to folks listening. And Dawn, obviously, you know this firsthand. A, clinical trials and why it's important that we figure out these things that you're talking about. But B, there tends to be, I know a lot of people that sign in tend to be like, oh, everybody in the room has a target, right? They're EGFR or they're ALK or they're ROS1. And so there's sort of these lonely people feeling lonely, sort of left behind because they don't. But this is a really good potential option.
No, I think that's a really good point, and I think really stressing that this is a common denominator.
Yeah.
For a long time in lung cancer, we were trying to find just smaller and smaller cohorts of patients that had certain genes and such. And I think kind of we may be understanding that they're common denominators, and how can we go after those common denominators across patients? That may even be common denominators across type of histology, genomic, smoking status, kind of these types of things.
And I don't want to I don't want to put in a plug for our registry, but I'm going to, because that's the whole reason we started the registry. This is as it's happening data that's being put in there by patients. And even though we only have about 800 or 900 patients in there right now, you can also already start seeing some patterns. And these are the patterns that are going to get us to more focused research, because we already have some information that shows that it can be promising research.
Yeah, and we'll talk a little bit more for those who are interested during the housekeeping part about the registry and what it means.
So along those lines, actually, I have a slide over here that just talks a little bit about how the immune system is actually interplaying. And there are really two key components to having an immune response against the cancer. So one actually is the fact that the cancer has to display itself with things that the immune system can recognize. And we call those neoantigens. And those neoantigens are processed through machinery that gets driven through in the cell, similar to how an EGFR mutation kind of causes a signaling pathway. There are certain pathways within the cell that change the expression on the surface of the cancer to make them visible and allow the immune system to get home to them. Historically, through time, the cancer cells have developed ways of putting on cloaks or brakes to prevent the immune system from attacking. And those are called checkpoints. And specifically, actually, the immune system has negative checkpoints that keep the immune system down so that we don't overshoot. So the way that that has interplayed is by regulating the T cells, by affecting their PD-L1 capacity to bind through an antibody or a set of antibodies. That's how the immune system drugs are working. Those are not the only immune drugs. We may see other checkpoint antibodies created for, as I mentioned, PD-1 or PD-L1, but also other checkpoints. And those actually are expansive, include molecules such as CTLA4, and you may hear about that, or another one called LAG3 or TIM3. These are all checkpoints that exist that allow the immune system to either get revved down or revved up. But I wanted to highlight the point that it takes two steps to have an immune response. First, actually, it has to be that the immune system is somehow, or that the cancer is somehow drawing the cells to it, so that the cells are being recruited, the immune cells. But then also, it has to have the brakes taken off. So it needs these 2 points. Okay, so here is a slide actually, which, in my mind, really kind of conceptualized some of the further work that needs to happen to understand the pairing of chemo and immuno. And again, this is actually from a mouse model in which it was a KRAS mouse model of the gene, and actually showed that if you looked at immunotherapy by itself, it had a reduction in cancer, but it wasn't a full reduction or kind of as good a reduction. If you looked at the chemo by itself, it didn't have a full reduction or, or such. But when you look at the combination together, there was more enhanced effect. And furthermore, when you looked at the tumors within the mouse, all of those tumors had T cells that had been recruited into the tumor, which means that the reduction was precipitated by the fact that the immune system got revved up.
So I think for their benefit, you can see the upper right, you've got untreated, and then on the right at the top is the combination of the immunotherapy. Lower left is chemo by itself, and then bottom right, those pink images, you can see the reduction in the dark purple areas, so that's showing the reduction in the tumors with the combination of chemo and immunotherapy. And then he's saying that in the blue bars, you can see an increase in the CD8 T cells in the presence of the combination.
Yeah, exactly. So they're working synergistically. They're not working totally independently. Okay, so want to highlight and just summarize that point, that I felt that this year's ASCO meeting was important because it really showed how broad this concept of combining chemo with immuno will be, in my view. So some of the other take-home points as it pertains to the immune system were that we got more data about an emerging biomarker outside of the molecule PD-L1. So to understand who's going to respond to immune therapy or not, I mentioned that it takes it's this two-step process. It's a priming, meaning the cells need to know when to be recruited and how to be recruited, but then also the brakes need to be turned off. So PD-L1 speaks to the brakes. The other thing that has come about is that the amount of mutations, the number of mutations that exist within a tumor may be important for priming the immune system additionally. And so that's become termed as a concept called tumor mutation burden or tumor mutational burden. Interestingly, the cancers that are responding the best to immune therapy are melanoma, lung cancer, bladder cancer. These are cancers that have very high numbers of mutations. In fact, actually caused because of the fact that carcinogens or such can cause that amount of mutagenesis. In melanoma, it's UV light. Lung cancer can be caused by smoking, and that can be associated with high tumor mutation burden. And bladder cancer, interestingly, is also affiliated with smoking because the carcinogens can collect within the bladder as they're released and excreted, and that can cause the mutations in the bladder. And you wouldn't even think about it because how is the bladder actually getting access to these types of things? So what we saw in this meeting was the fact actually that this readout called tumor mutation burden, which is just a numerical counting of the number of mutations that are thought to be oncogenic per megabase of sequenced DNA, that if one has a greater than 10 number by a Foundation Medicine assay, that was very predictive of a response to the immune system drugs.
And those are not just in lung cancer panel. That's in your entire test. So if you
That's
did
a very
the
good point.
Foundation Medicine 320 gene, that's the one we're talking about. We're not talking about the
Yeah.
yeah.
No, that's a
People
very
get
good
confused
point.
about that.
That's a very good point that Bonnie's bringing up is that you need to kind of survey enough genes. And right now, and from a research standpoint, we don't know what is the magic number of genes that totally need to be surveyed, whether or not it's thousands of genes that need to be surveyed or 365, which is on the Foundation panel. But there have been studies that have tried to correlate what's called a whole exome account for tumor mutation burden versus the Foundation 365 gene for tumor mutation burden, and have shown concordance, between that. So we trust that a little bit more now.
Barb has a question.
Yeah, I just had a question. So where does that information come from? Does that come from a biopsy or
So that's a good point. So that would come from the biopsy, and once the biopsy has undergone genomic sequencing, and it has to be a panel that has a sufficient number of genes, so in the order of, say, 300, 360 genes plus. And right now, we have the most data with the Foundation Medicine platform. And the data that I'm actually going to present is the one that's kind of listed on the lower panel, in which, and it may be hard to see completely, but in red, you can see that with the combination immune drugs compared to chemo, even for people that had low PD-L1, the immune system drugs did very well if there was high TMB or in the setting of high TMB. So I think kind of that was summarizing point number 2 about the immune system is that we may be having a new emerging biomarker. So it's maybe not totally enough just to know PD-L1. We may want to at least ask our oncologists about TMB and what their thoughts are about TMB.
Not to call you out, Don, but didn't you share a similar story with your diagnosis?
I'm on that new triplet, so I'm responded very well to the Keynote 189 trial. I had 50% reduction in tumors after only 4 infusions. But I was tested for PD-L1 expression a few years ago when I started on immunotherapy, and I only had 2%, which is moderate. But on my foundation report, I had a tumor mutation burden of 17, which 20 is, I think, and above is considered high, so I'm sort of high moderate. So, and I've been on 3 different immunotherapies: Opdivo, Tecentriq, and now the triplet. And my tumors have never grown on any of the immunotherapies. I did have some malignant cells in my periocardial sac and only 5% malignant cells in my lymph nodes. So I've been responding very well to immunotherapy.
Yeah, and I think that's why, and I think you had kind of previously mentioned actually that that some of the doctors were considering the nivolumab and ipilimumab combination. And that's probably because of the fact actually that they're linking on to the fact that you have that tumor mutation burden of greater than 10, which is the cutoff in this.
Isn't your boy or the target CTLA-4, is
Yeah.
that more in the lymphatic system?
So that's a really good question as well, is that our immune attackers, these immune cells, they're circulating through all of our bodies at any given time. But they home and they get more education per se, or more memory response when they're in a lymph node. So by virtue of affecting those dormant cells in the lymph node, to making them more active, as well as at the periphery where the cells are in the cancer, that two-step process also may be important. And that was the premise behind why combining PD-1 plus CTLA-4 may be helpful.
But then the CTLA-4 interacts with a molecule called B7, and that's part of the co-receptors for T cells, and part of that pathway. So when we go back to that slide, looking at the interaction between the tumor cell and the T cell, it's another compound or another set of proteins that interact on the cell surface of those molecules.
Yeah. Okay, so just want to highlight actually also, and just kind of, I've mentioned this, but just to highlight the fact that this concept of chemo and IO is even going broader than just non-small cell lung cancer. I mentioned small cell, and there will be data presented at the end of this year, likely kind of further elucidating how chemo primes with the immune system. But then even broader out than lung cancer is that the strategy seems to be applicable in mesothelioma as well. So next, actually, I'm going to switch gears. So I spoke a lot about the immune system, some of the relevant kind of strategies that are being vetted, and some of the data that's coming out on that. Now we're going to kind of look at targeted therapies. So many of you actually have been affected by the EGFR mutation, or the EGFR mutant form of lung cancer. And there's been really great advances with new drug development in that space to target the resistance that could even happen after erlotinib, gefitinib, or afatinib, with the new drug osimertinib. And some of the big things at ASCO as well were better trying to flesh out what are some of the mechanisms of why osimertinib may stop at the point that it does stop. And so we have a little bit more clarity on some of these things. We're still waiting on more data. There can be other genes that come up. And so the ways that clinical trials are trying to approach that are by combining different agents, osimertinib plus a drug that targets MET, other types of events like this. Like with Tarceva and gefitinib and afatinib, there was a new mutation within EGFR. There may be other mutations in EGFR that we have to know about after osimertinib, and we're still trying to understand those. But those do not seem to be a major component right now compared to the bypass pathways. So on the heels of this, our knowledge of EGFR has really kind of set the stage. You know, what the lessons that we learned from EGFR were ones actually that now we're taking beyond EGFR in the setting of ALK, ROS. But also there was some new compounds for different genomic aberrations, specifically fusions. So I'm going to highlight kind of the fact actually that some of the lessons of EGFR are coming outside to other genes, and RET fusions were ones that were really spoken about at this year's ASCO meeting with 2 compounds actually. So the LOXO 292 compound, as well as another compound that was spoken about at a previous meeting called AACR, called the Blue 667 compound. So we're seeing that not only are we getting continued development of these new pill-based drugs, we're getting them for different genes, and they're showing really good benefit. So also kind of another area of unmet need in the EGFR space was with a specific type of EGFR mutation called the EGFR exon 20 insertion. So those types of mutations don't respond to Tarceva, gefitinib, and afatinib, and even osimertinib that well that we know of. But there are new drugs being created and positioned for the exon 20 insertion, and we heard about a drug called TAK-788, and there is data about another drug called poziotinib. So these are new drugs. It's always good to kind of just be familiar with some of the new drugs that are coming, especially for those targets that previously have not always had good efficacy.
I would just interject here a couple of things in that through Alchemy, our sister foundation that does all of our research studies, we've had some follow-up conversations with the company that is developing Blue 667, and we're also going to be talking with LOXO, and the data looks incredibly compelling, I would have to say. It's exciting that, again, we are kind of using this approach to develop drugs that target additional mutations or fusions. One side note, I think in some of the data we were discussing, we'd also talked about dacomitinib, and it's an irreversible TKI, tyrosine kinase inhibitor, and so I don't recall the specific data around any side effects of these, but with some of these newer drugs, that is an issue to be aware of, is any adverse events. I think DACO, did have, not unmanageable, but did have some, increased side effects just because of the nature of the drug and how it interacted with its target. So, as you explore these options for yourself, that's just something to keep in mind is,
No, I think it's a really good point is that now that patients are on the drugs for longer periods of time because the drugs are working, we have to really be cognizant of the tolerability of the drug. And I think that some of the reasons why the drug osimertinib has actually gotten a lot of improvement is because it has clinical efficacy, it has really good tolerability, and actually it can prevent brain metastases in some patients.
Mm-hmm. That's what was asked.
And so that's why it's good with some of these newer drugs, learning on the lessons of what wasn't working before was why these newer drugs were even designed in some of those ways.
One of the questions that's come up, and I haven't really seen a consistent answer, is like, so if you've been on Tarceva and you're thinking maybe, like in Dave's case, where he had brain mets, it might be better to move to Tagrisso. Obviously, even Tagrisso doesn't work for everyone. And so if it's not working for him at all, can you go back to Tarceva, or is that
so that's a really good question. And I think the jury's still out right now because there may be certain indications after Tagrisso that Tarceva or gefitinib may work. And specifically, if there's a new mutation that happens in EGFR called the C797 mutation, and if it exists in a specific conformation, then actually Tarceva and gefitinib may still respond.
Right.
Yeah.
I wanted to mention too, LOXO's drug is starting to look really good for RET as well.
Yeah.
That's what we're talking about,
Yeah. Oh, sorry, am I skipping ahead?
Yeah.
I was going to say I have 2 or 3 friends in that trial, and they're getting amazing results with real mild side effects.
Mm-hmm.
Okay, so here is actually just the data from the LOXO compound for the RET fusions. And you can see that this is, called a waterfall plot in which we see that every bar below, the major 0 point is a response. And if it's below the dotted line, that means greater than 30% reduction in the cancer. And so we see that even in lung cancer, but also thyroid cancer, if you target for the RET fusion, you can have good responses. And then below that, I have the data from the blue 667 compound, which shows similar kind of good responses, and then also highlighting the fact that these responses are durable. We still don't know how the two drugs compare against each other, and obviously kind of those are interesting questions that need to be explored.
LOXO will tell you.
Yeah. Okay, so lastly, I'm going to speak about something I get very passionate about, and something I think has really been like a game changer in lung cancer in certain ways, is the ability from a blood test to identify genes that may have been responsible for the cause of the cancer. And this really kind of goes into this concept of what's called circulating or cell-free DNA. So all of us have circulating DNA. And in fact, actually, if we run a marathon, we have a substantial amount of genome fragments that are just circulating around in our blood. If we are, have pneumonia or something like that, we can have higher percentages of these circulating fragments. And when cancer is there, it can also lead to cellular turnover to release out fragments that are specifically coming from the tumor. So there have been sophisticated technologies that have been built and designed. Many of these have been pioneered out of Johns Hopkins, and now kind of companies and commercial companies have pioneered technologies. And these technologies actually look at how from a fragment can you sequence that small fragment size to give you an idea if there are any cancer-causing mutations on them. So, this is a slide which basically shows in the upper right the fact that these fragments are wrapping around proteins, and those proteins get degraded, but they get degraded in very predictable ways by virtue of the laddering that's shown on that blot. So by virtue of looking at the specific sizes of the fragments, one can figure out, firstly, are they cell-free DNA or not? And then actually when they do sequencing on them, they can figure out, okay, well, what genes are on them? And are there any mutations in genes on them? And this has been an important avenue because specifically as we need to know the information quickly, it can take long delays, and we heard about some of the long delays actually with tissue, that from a blood test we can find some of these. It's not always helpful if it's negative, because sometimes the tumor doesn't shed enough, but if it's positive, it can be actually very helpful. And in fact, actually be useful to identify EGFR mutations, ALK fusions, ROS1 fusions, BRAF mutations, MET aberrations, and all of these actually have drugs that can be used for them.
I think that's what he's showing, that word above the box. Apoptosis is a programmed cell death pathway, and so it activates kind of a series of enzymes that are going in and cutting your DNA into very discrete units. So these 180 base pair fragments that's on the left, you're looking at gel where these dark bands are indicative of DNA. And so you can see kind of these hallmarks of apoptosis in these very discrete sizes.
Yeah. So at this year's ASCO, Jeffrey Oxnard out of Dana-Farber Cancer Institute really kind of gave some interesting approaches for early detection of lung cancer using cell-free DNA. And there have been many groups actually that have been trying to do this. I've highlighted in this slide a paper that was published in a very high journal from Johns Hopkins, in which on the first upper left panel, you can see that patients who have cancer may have higher detectable DNA to those people who don't have cancer, but not by huge amounts. But when you look at the specific mutations of cancer, and you add in that level of, say, looking for the specific genes, in this specific assay from Johns Hopkins, patients who had lung cancer, breast cancer, colon cancer, those patients could have detectable values compared to patients who did not have cancer. So that meant the test was pretty specific. Furthermore, actually, with stage 4 versus stage 1, there was more detectability with stage 4, which shows the predictable kind of thing that more cells may be releasing more DNA. So what was presented by Jeff Oxnard was the fact that there's been further work to try to tease this out and broaden it so that we're not just looking at mutations in specific genes, but we may be looking at methylation signatures. We may be looking at copy number gain and loss. And when you add in the composite of the mutations, copy number changes, methylation, and at Johns Hopkins, they had actually even added protein levels. When you add all of those together, you may be able to increase the sensitivity to find even the smaller cancers. So I do think that, in my humble view, I mean, I do think that at some point, actually, that there will be a strategy about how to use blood tests to better inform even early detection. And maybe that may coincide and parallel and go complementarily with low-dose CT screening and all the rest. And I think the field still needs to tease out how to do that.
Yeah, I think there's a fair amount of debate still about liquid biopsies. And, there's really a continuum of companies that are looking at different points. Like GRAIL is very focused on early detection. Can we detect a cancer before it may even be visible on a scan? Then kind of middle of the road, you might have a company like Natera that's really looking at monitoring a patient response to treatment. And can that either be used to, kind of this watch and wait? We have a patient who's doing well and maybe we can not give them treatment for now, so we can kind of have that conversation. And then you've got groups like Guardant or Foundation Medicine who are using it to help make treatment decisions. So there's a whole continuum of how companies are approaching this, but I think there's still, a healthy amount of debate. There's only one FDA-approved liquid biopsy test currently on the market. There's a lot that are in development, and there are different things that you can look for in the blood. You can look for circulating tumor cells, or you can look for DNA, and those have kind of pluses and minuses depending on what you're trying to do. For example, if you get cells out, then you can look at, from those cells, you can isolate DNA, you can isolate RNA, you can isolate proteins. That gives you kind of more things to look at, and you have the benefit, potentially, of being able to grow those cells in culture and use those for additional studies. If you take the approach of just looking for DNA, you can look for mutations in the kind of work that you're talking about. Some people are looking at the use of RNA, circulating RNA, and that has utility as well. RNA is a little less stable than DNA in the long term. It tends to degrade more easily, so it's kind of harder to work with. But I think, the combination of all those different things, is useful and gives you different information and kind of can be used in a complementary way. But I think, there's a lot of excitement, a lot of work going into liquid biopsies. I don't think we're there. It's not quite ready for, prime time. We're having this discussion, but certainly we're headed that direction.
Yeah, I think, there's been unprecedented movement. And so while we may not be totally there just yet, I do think that with how quickly things are happening in cancer nowadays, that I do think so. And I do think that, as Amy has brought up, is that by having combinatorial assays that are including protein plus DNA plus copy number, the mutations, the methylation, all of this together, you're going to have a very comprehensive analysis. And this is going to be helpful for people who don't know that they may have cancer and early detection, or actually for patients who do have cancer that we want to use for monitoring. Because we now appreciate, by this experience that we've had with EGFR, kind of understanding that cancer can change through time. And so we're going to need better tools to kind of understand how the cancer is changing that are non-invasive and less invasive to do so.
But there are still, I'm just sorry.
No,
to
go
cut you
ahead.
off.
I just have a question.
Caveats within this, and I think we've heard it expressed as we've been around the room tonight, that sometimes you get a blood sample and they can't find any DNA. And, and different tumors behave differently, and that can, some of them shed more readily. Some of them, don't shed as much DNA. And, so it's that conversation of false positives versus false negatives. And, are you capturing, even if you do obtain the DNA or obtain the circulating tumor cells, are you capturing the heterogeneity of the tumor? Is it fully reflecting the totality of what's going on in the tumor itself? And so, there are considerations there. I think, together it's one of those things that's another tool in the toolbox. I don't think you can look at in isolation, but it is, the field is advancing that way, and I think it is something that shows great promise.
But it could get us to start a screening program for those patients where it looks like that might pop up pretty soon and catch it really early.
Yeah, I have two questions. So one, based on something you just said, Amy, about the heterogeneity of tumors, isn't that like grabbing that information even from a tissue sample? I mean, it's a challenge, right? Whether it's in the blood or whether it's a tissue biopsy, right?
Yeah,
It's still
totally.
Still a challenge.
Yeah.
And then, so that I just wanted to clarify
But one
that.
quick thing about that, though, is that from the blood, conceptually, you're getting DNA from a tumor that may be here, as well as here,
correct?
As well as in different other spots.
And that's, I think, what I was saying. Like at some point, when we can get these blood biopsies, or to where we need them to be, the potential for them to actually be better, right?
Yeah.
Based on what they can pick up. To your point, from varying places.
And faster.
And faster.
Yeah.
And hopefully cheaper.
Yeah.
Well, I mean, Natera
At some
has
point.
studied with their, assay that they're developing that landed on the cover of Science, So, I mean, that's one of the premier journals in the field. So, I mean, there's a lot of excitement in the field in general about the promise of liquid biopsy. So I think, we'll get there, but.
So my second question.
My other question would be a spit. Some people out there, like 23andMe, say anything you can get in the blood, I can get in spit.
Yeah,
is that close?
So,
she says spit, so I'm saying spit.
I mean, I think, so to do these things, the things that are important are the fragment sizes and the amount of material.
Right.
And so, some of the challenges with saliva is that it's hard to get huge amounts. I mean, you can get it, but it takes a long time. Urine actually was very interesting because you could get a lot of it. But the problem with urine is that the fragment sizes in the urine were small. And it's hard now to compete against blood because there's been so much definition and so much research in it that we understand it better than the other two. So my personal kind of opinion is that we're going to need a little bit more time to understand how the different other compartments will play out.
So my sort of last question about this, and then please everybody feel free. So whether it's in the sort of monitoring the disease and or the early detection space, and I won't hold either of you to your opinions on this, but how far out do you think we are before they become like standards of care?
So I think, in my view, I don't. So I think if it's positive, it may be helpful. I think if it's negative, it still doesn't mean that that you're not going to detect it. In fact, from the Hopkins study, about 50% with stage 1 or 2 lung cancer could be detected from the blood test. Okay, and so what that means is for at least 50% of people, you can find it. So when one thinks about, okay, well, what is necessary for it to get approved? I think some of the questions that need to be answered are, what is that threshold? Even if it can help 50% of people, is that sufficient? In my view, it is. But maybe, some of the health economics and kind of all of those types of things, it may not be. I don't know, kind of with those. So what I think is that, I think the technologies are moving so fast that we may have as good a technology as we may get in the next 2 to 3 years.
Yeah.
And then I think it's going to necessitate, okay, well, how does the field converge together to say, okay, well, how are the studies going to be designed and how are they going to be paid for, right, to kind of complete? And I think with those in mind, I think that will define if it's 10 years or if it's less.
I agree with that. I mean, and I think it depends on what application you're looking at here. You know, again, having the conversation recently with Natera, they're going to get their CLIA certification, you know, first quarter next year, 2019. So in terms of treatment monitoring, that might be, you know, a little bit more ready to go than are we fully there on early detection. I do think, you know, within the next 2 to 3 years, we're going to see a lot of movement. And then, you know, we're going to have to do lots of trials to kind of bear this out. So that's kind of the next big thing is, you know, doing the trials and figuring out if it works.
Ron, do you have a question?
It's fascinating. You know, urine had big potential early on, and then spit, and now we're talking blood. My question is breath. Breath detection has been touted as early detection possibilities for, I think there's a team in Germany and another one at MIT, and they're thinking, you know, the percentages of RNA that are in there, if they're off, that would be an early detection model. Or if they're a certain percentage of certain types of RNA, then that would be a model as well. To me, that would be the simplest thing, because if cops can walk around carrying breathalyzers, why can't docs, you know?
Yeah. No, and that's a really good question. And in fact, actually, at UC San Diego, we are actually working with a company on that process from a breath test. Can we identify the fragments of DNA? And I think that what's interesting about that is that if there's tumor, I mean, presumably you can. Originally, kind of these breath tests have been more geared towards can we find certain infections, like say like tuberculosis. So what they found when they were trying to do these tests for infections is they found that they could find a lot of human DNA within the breath material, like within that, and they could capture it. So the natural extension is that if someone has cancer, and we were looking, say, for, you know, kind of if we found the genomic DNA when we were looking for, say, infection, now can we reposition it to look as an early detection tool for cancer?
I actually worked with a researcher in Georgia who's a breast cancer specialist, but she was working on a breath test for breast cancer, and then was approached by a contact I knew back there who works with the Canadian consulate, and she's working with a company who's also trying to develop a breath analyzer test. So I should get with you and just compare notes. Because I do think there is interest in the field, and then, you know, it's not limited to just lung cancer.
And we may need multiple things. You know, I mean, one of the attractions around urine originally was that, you know, we could get urine and blood, and we could try to kind of increase the volume, because the problem with blood is that we can only really collect a limited amount at any given time, and that was hindering our ability to even detect. And that's why if one gets a negative result, one of the questions is, was there enough sample, right? Was there enough there? So if we can use other things, especially for the blood negative results, and maybe, you know, that may include, you know, such strategies such as urine or breath or other things like that, that may be helpful. So just to summarize, you know, kind of, so today we spoke about, you know, 5 major points. So one was about how the frontline management of lung cancer has been affected by immunotherapy, either alone for the high PD-L1 or in combination with chemo. We spoke a little bit about how PD-L1 testing is really defining out what patients may get in the front line. So having those results available are important. We spoke a little bit about why and the need for still continuing to need the genomic information in the front line before patients start therapy. And part of that is to find mutations such as EGFR, ALK, ROS, you know, these types of mutations. But then the other component is that there may be other emerging biomarkers such as TMB that rely on the genomic data. And then we spoke a little bit about some of the new drugs in the targeted space, you know, specifically around the RET fusions and the exon 20 insertions. And then lastly, kind of early detection using the cell-free DNA. And we still don't have full clarity on it, but we hope actually that, you know, within, sometime soon, actually, that we may have the right strategies to apply for them.
How much work is being done on the exon 20 insertions? Because, we don't see the EGFR mutation in a lot of other cancers, but we do see the exon 20 insertions in other cancers.
No, I think it's a really good question. And I think historically, the reason why the field was a little bit limited was because we were positioning the EGFR inhibitors that we had to just see if they would work. But now actually there's been, some designing aspects to actually design it for this mutation. And also we've seen some positive hits, and I mentioned the two drugs, the TAK-788 as well as the poziotinib, and they're showing really good benefit. And I think we just need to understand what the full toxicities of the drugs are and how long the benefit is for. And so for the targeted inhibitors, some of the questions to also ask are, how long is the drug going to work for? Not only just how many patients will initially respond, but how long, and actually what is the tolerability during that length.
Do you see us repurposing a drug or two for other cancers?
So in fact, actually, so poziotinib was originally designed to be a regular EGFR inhibitor, like erlotinib, gefitinib, and afatinib. And actually, many of these drugs were also kind of geared towards, because they target T790M. And it was only retrospectively found that it doesn't actually have as good efficacy for those mutations, but it does for the exon 20 insertion. And so I do think that we're going to have to, never it's always good to just, continue to know what has been tried, what were the limitations, how well was it studied across all the different diversity of mutations, can it be repurposed? And that's why even the erlotinib, gefitinib angle after osimertinib, there may be a role.
So I think Don has a question, and I want to be mindful of time, so go ahead.
I just had a real quick question.
Yeah.
Dr. Hussain, what was your takeaway from ASCO on what's promising in small cell lung cancer? My girlfriend passed in 2014 from small cell, so I get a lot of people that are reaching out to me about small cell. I know Opdivo and Yervoy combo. I know the MEDI 4736 trial was, that's been FDA approved now for immunotherapy, and also AbbVie has the new one, Rovati, that targets DLL3. What do you see as the most promising thing in small cell?
So that's a really good question. So at ASCO, there was data presented about the drug Keytruda or pembrolizumab in second-line small cell, which actually showed good benefit. And in fact, actually, it also had higher benefit for higher PD-L1. And before, in earlier studies with the immunotherapy, PD-L1 didn't always stratify out as needing really high expression, for that. So tumor mutation burden also is predictive of immune therapy. I think that one of the bigger things we're going to hear about at a future meeting, the World Lung Cancer meeting, which will be this combination of chemo and immuno in the front line. And then Rovati was discussed at ASCO. I think certain things that we're waiting on are some of the larger phase 3 studies to give us full clarity, because we still don't know how that drug is going to play out. We do know that a lot of small cell expresses the molecule called DLL3, which is the biomarker that Rovati will target. And the way that that drug was designed was it has an antibody on it, specifically for the DLL3, but then it latches on to chemotherapy so that the chemo can be delivered just to the DLL3 expressing cell. They call that a conjugate, like with a linker. And so with that, actually, I hope that that's an important drug. I do think that there's more discussion about immunotherapy for small cell rather than targeted therapy for small cell.
Exactly.
Thank you.
So we've got a couple of minutes left, and I want to get to a couple of our housekeeping things. But first, I want to give a huge, huge thank you to Dr. Hussain and Dr. Moore for coming out and talking to us. I think this was a really great presentation, giving some really great information and some key specific areas about what's happening. So I'm hoping we've been able to touch a lot of folks with the information that came out today. So thank you both. So up next, August 2nd, we'll be in Hollywood, Florida for our Hollywood, Florida living room. So if you guys are so inclined, please tune in from out here in California. And those of you online, if you're in South Florida, I fully expect to see you there. I think some of you probably are. And bring your friends. August 6th, we'll be in Denver, Colorado. So this will be our first Denver living room. We're working with University of Colorado, Ross Camage, and a couple of other docs, Dara Eisner and Chad, I can't pronounce his last name. No, that's Boca. I asked Michelle earlier, and I was like, I haven't met him in person, so I feel really terrible if I botch this, but it's Russ Thoven. So it's going to be a great living room. So the Florida one is lung cancer in the area of targeted immunotherapies. And then the importance of a multidisciplinary team is what we're going to be talking about in Colorado. So we're really excited to get out there and do those. August 21st, here in our home offices, Dr. Heather Wakelee from Stanford. A lot of you know Dr. Wakelee. She's been here and spoken before, so we're really excited to have her as well. Upcoming events. 2 upcoming events in September. September 16th, also Hollywood, Florida. So my living room peeps, be ready to get some information about that. Luckily, it starts really early in the morning. And then September 23rd, our San Francisco 5K. So any of you who...
29th.
Oh.
Thank you.
Sorry.
Thank you. Thank you.
Thanks to the people.
Some people are paying
I got
attention.
bad information on here. September 29th, San Francisco 5K. So there's flyers, there's information. If you haven't already signed up for any of these events and/or events that are in your area, they're great fun. It's such an awesome day to be able to get out, spend time with one another away from sort of the cancer space and just enjoy a nice afternoon. So I really encourage.
And if you have children and grandkids, bring them because we have a little race for them as well, and they all win medals, and they're very excited.
Yeah. Before I do my thank yous, I got my papers mixed up here. You'll see some of the folks in the room, and those of you watching online saying I joined the lung cancer registry buttons. So Bonnie's got one on here, Dawn's got one on, Tina's got one on, Ron's got one in the back. These buttons are just sort of a thank you for going in and signing up for our lung cancer registry. You touched on it a little bit earlier, and I think it's important for a multitude of reasons, but one of the things, to your point, Mom, is that it creates this opportunity for people to find patterns, for people, researchers, scientists and researchers out there trying to fight for your disease and have come up with new learnings, really be able to gather and access that information.
We have a study going on with it right now, looking at patient-reported outcomes from immunotherapy. So, I mean, that's really important to hear it directly from the patients, what they're experiencing.
So if you're in the room and you have signed up, please grab a button. If you have not signed up, please grab a flyer, and I will go ahead and assume you're going to sign up so you can take a button too. No, I'm teasing. You can take a button anyway. But this will tell you where to go, how to do it. I did it, I created her profile.
That's me.
This one's
I'm her.
for her. And I think it took me 15 minutes. I mean, it does not take very long to do. And it's a really, like I said, great resource for all these great folks to go out and kind of mine that information. So to the thank yous, and then we can get to the good stuff. The Office Bar and Grill, obviously, for once again bringing in all of this food. Peninsula Television for tirelessly bringing all of this equipment here every month and broadcasting it out for us. To our sponsors, AbbVie, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Genentech, Lilly, Medtronic, Merck, Novartis, Takeda, and the Yahoo Employee Foundation. This is a really popular program with our sponsors and folks in industry. They truly believe in being able to provide this type of an atmosphere and bring it all to you. So a huge thank you to them, and most importantly, a huge thank you to the patients and caregivers in the room who consistently come in here and share your stories, not only with us, but with all these people watching online live tonight and those that will come back later to watch. I thank you.
And online.
Thank you.